Hello, everyone. My name is Dr. Gurshraman Singh Kochhar, and I'm a second-year internal medicine resident at Cleveland Clinic, Cleveland, Ohio. I'm present here in front of you all to present my poster titled Factors Which Impact Readmission in Those with Liver Disease, a retrospective case series. As we all know, beginning in 2012, readmissions will be taken into account by CMS for reimbursement. Hospitalization for patients with chronic liver disease is common and costly. Reducing unnecessary readmissions is important to improve efficiency, to improve quality of care, and reducing cost. Many studies have been attempted to identify risk factors for readmission prior to discharge among patients admitted for CHF, COPD, and pneumonia. There is a lack of data looking at recurrent readmissions in patients with end-stage liver disease or patients with cirrhosis. Recently, a study evaluating readmissions rates in cirrhotics found an association between male gender, presence of diabetes, and MELD score at time of discharge with 30-day readmission. Although this data may be helpful in risk stratifying cirrhotics, it did not look at multiple readmissions and did not look at organizational or modifiable factors associated with readmission rates. We conducted a study to review and find the predictors or risk factors of 30-day readmission rate of hospitalized patients with end-stage liver disease, and we assessed if there were potential organization modifiers that may reduce readmissions. Our hepatology inpatient service serves patients seen in our outpatient clinics as well as those who are referred to us for liver transplantation. Additionally, we have a large inpatient transfer program for patients who may require additional treatment of their underlying condition. We reviewed all medical records of GI readmissions from the Outcomes Review System, which is an enterprise-wide tracking system used to monitor all readmissions and mortalities within this Cleveland Clinic, and is maintained by the Quality and Patient Safety Institute at the Cleveland Clinic. We assessed all readmissions to our hepatology inpatient service between September 1, 2008 and September 1, 2010. Readmissions were defined by the Outcomes Review System as an admission to any service within 30 days from index admission discharge date. For this study, all patients with an index admission to hepatology service were included. Patients who carry a diagnosis of liver disease were included regardless of admission diagnosis. 293 patients were included in this study. Data was collected for both the index admission and readmission. Variables included the reasons for readmission, tests which were performed, MELD score, scheduled follow-up, whether patients made the follow-up, and whether there were a nutrition or a medication compliance plan. Means, standard deviation, and percentiles were calculated for continuous variables, and frequencies and percentages for categorical factors were calculated. Univariate analyses were performed to assess differences between subjects with multiple liver-related readmissions and those with only one readmission. Students' t-test or the non-parametric Wilcoxon rank sum tests were used for continuous variables, and a Pearson chi-square test were used to compare categorical factors. In addition, a multivariable logistic regression analysis was performed in order to assess association with multiple readmissions while adjusting for baseline MELD score. So of 293 patients, 232 had one readmission, while 61 had multiple readmissions. Of these, 87% of patients were readmitted before follow-up. Of these, 50% never scheduled an appointment. 5% had a scheduled appointment within 7 days, and 25% of the patients after 22 days. 65% of patients were readmitted within 2 weeks of initial discharge. There was no evidence to suggest that any other issues like tests performed during first readmission or plans for nutrition or hydration were associated with multiple admissions. Shorter duration of stay during second admission was associated with need of multiple readmissions. In our study, MELD was inversely related to the readmissions. Additionally, patients with ascites and encephalopathy were more likely to be admitted. Given that neither ascites or encephalopathy are factored into MELD score, that in fact the patient being scheduled more frequently may be sicker, but that this may not be reflected by the MELD score. Medication non-compliance was associated with multiple readmission, which is not surprising. Interestingly, in almost none of these patients was there a plan to improve medication compliance. In summary, this study identified several predictors of readmissions in patients with advanced liver disease. Low MELD score, history of ascites or encephalopathy are independent risk factors for multiple readmissions in patients with advanced liver disease. Additionally, we identified that patients are oftentimes not scheduled for an outpatient follow-up that the duration to outpatient follow-up is long, and that although medication non-compliance may be an issue, there is oftentimes no process for improving compliance. Future studies should focus on validation of the above risk factors and in the assessment of whether improvement of certain processes-related issues reduce readmission rates. Thank you.